Assalamu alaikum warahmatullahi wabarakatuh. To carry on with the embryology lectures, I'm going to talk today about the development of the kidney. I'm Dr. Dalia Saleh, professor and head of anatomy department at Mansoura University. The objectives I'm going to cover in this presentation will be, first I'm going to give you a brief introduction about the mesoderm. Then we will talk in details about the development of the kidneys in its three stages: the pronephros, the mesonephros, and the metanephros. Then we will talk about the ureteric body and cap, the ascent of the kidney, and the anomalies in the development of the kidneys and ureters. To start with the mesoderm appears between the ectoderm and the endoderm. This is the ectoderm and this is the endoderm, and this layer is the mesoderm. It appears between the ectoderm and the endoderm during the third week of development, and it will be divided into or differentiated into three areas or three parts. The one next to the axis of the body, which is represented here by the notochord and neural tube, is the paraaxial mesoderm. This paraaxial mesoderm will later on be divided into blocks. We call it somites. Lateral to it lies the intermediate mesoderm, and lateral to the intermediate mesoderm we have the lateral plate of mesoderm, which will be divided into two layers, somatoploric and splanchnoploric layers, and separated from each other by the intraembryonic xylem. The kidneys will develop from this part, which is called the intermediate mesoderm. Here in this diagram, you can see a section in the embryo, longitudinal section in the embryo. This is the head region. This is the tail. This is the heart. This is the umbilical cord. This is the GIT, or the gastrointestinal tract. And we can see here the intermediate mesoderm. This area represented here by the intermediate mesoderm. So the intermediate mesoderm will give rise to the following: nephric structures, parts of the gonads, and the male genital duct system. For the kidneys, it arises mainly from the intermediate mesoderm. There are three kidneys appear in succession. First, the pronephros appears in the cervical region and it is non-functioning. Then the mesonephros kidney appears at the thoracolumbar region and its temporary function. Then the metanephros, or the definitive kidney, appears. So what happens is that the intermediate mesoderm become segmented into small units. Each unit we will call it nephrothomes. Some nephrothomes acquire lumen and elongate to form the nephric tubules. Then a rod-like structure appears dorsolateral to the nephrothomes. They form a longitudinal duct on each side of the embryo. They arise both in the cervical region at the pronephros kidney, and they carry on the thoracolumbar region connected to the mesonephric kidney. The pronephros kidney, or the pronephros stage, like we said, it appears at the cervical region of the embryo around the 21st day of development. It is rudimentary and soon disappear like 3 days later, like at day 24 of pregnancy. It's never functioning in humans, just functioning in some fish or other lower vertebrates. For the mesonephros kidney, it arises at the thoracolumbar region. It appears early in the 4th week of development. In week 5, the thoracic segments regress, but the mesonephric kidney in lumbar region continue to function till the 12th week of pregnancy. So, like I said before, it is temporary function. In this diagram, we can see a cross section in the embryo. Here you can see the dorsal aorta, which gives rise to branches. And in this area, you have the intermediate mesoderm here. This will be the area that will give rise to the gonads, and this will be the area that will give rise to the nephric structures. So the mesonephric excretory unit, which we call it the nephric tubules here, communicates or contacts medially with a blood vessel arising from the dorsal aorta. So give us here the renal corpuscle. Its lateral end will join or empty into the mesonephric duct, which has another name. We call it the Wolffian duct. So in the lower lumbar region, the mesonephric duct grows in a ventral direction to open or empty into the cloaca. And the cloaca, if you remember from general embryology lectures, it is the terminal end or common terminal end between the GIT and the urinary system. Later on, it will be divided into dorsal anal port and ventral urinary port. At first, the mesonephric duct is a solid cord, then later on, canalization will take place in a craniocaudal direction. Then the third stage of development of the kidney is called the metanephros stage, or the metanephros kidney, or the definitive kidney. Here you can see, again, let's revise this diagram. This is the head of the embryo, this is the heart, this is the umbilical cord, this is the tail of the embryo. The blue area here represented or representing the ZIT, which opens into the cloaca, which is a common sac between the termination of the hind gut or the GIT and the urinary bladder or the future urinary bladder. On each side of the embryo, we have the intermediate mesoderm. Already in this diagram, the pronephros has regressed, and the mesonephros already has regressed in the thoracic region, and only the mesonephric part of the kidney in the lumbar region persists. Okay, this will form the mesonephric tubules or the excretory unit, and these lines or these solid cords represent the mesonephric ducts. The first appearance of the definitive kidney or the metanephros kidney appears in the 5th week, at the end of the 5th week of development. If we enlarge this area like this, what happens is that there are two buds arises from the distal end of the mesonephric duct upon its entrance at the cloaca. These are the ureteric buds. So again, this is the mesonephric duct which opens into the cloaca. At this point, two buds arises from the end of the mesonephric duct. We call them the ureteric buds. The ureteric bud induces or stimulates the intermediate mesoderm at the sacral region to differentiate into something called metanephric cap. If we talk a little bit about the ureteric bud bifurcates again and again and again, so many times, up to 16 times, to give many branches. Then the branches coalesce to form the major calyces and the renal pelvis and the ureter. Then the next 4 generation or the next 4 bifurcations of the ureteric bud will coalesce again to form the minor calyces. Then by the end of the 30 2 a week of development, another 11 more generations or bifurcations are added, and we end up with like 1 to 3 million branches of the ureteric bud. These will form the collecting tubules, as shown in this diagram. So to summarize what I have said before, the ureteric bud arises from the lower end of the mesonephric duct before it enters the cloaca. It grows towards the intermediate mesoderm at the sacral region to stimulate it to form what's called the metanephric cap. But what happens to the ureteric bud? It splits many times, and they eventually will form the collecting system of the kidney. They will form the collecting tubules, the minor calyces, major calyces, renal pelvis, and the ureter. The mesodermal cells at the metanephric cap will be stimulated by the ureteric bud, and the cells there will arrange as vesicles around the distal end of the collecting tubules. Remember that the collecting tubules arise from the ureteric bud. These vesicles will form a comma-shaped structures. With further development, they will elongate and form S-shaped bodies. Then they will get a lumen to form small tubules. These small tubules will later on elongate more and more. Their proximal end will form the Bowman's capsule, looks like the letter C, and their distal end connects with the collecting tubules here. Later on, the Bowman's capsule will be invaded by blood vessels to form the glomerulus. With further development, the tubules or the tubes elongates more and more, and they form the different parts of the secretory unit of the kidney, the proximal convoluted tubules, the loop of Henle, and the distal convoluted tubules. Remember that I said first that the metanephric cap develops at the sacral region, but actually the adult position of the kidney is in the lumbar region, so there is what's called ascent of the kidneys. In the 6th or 9th week of development, the kidneys begin to ascend from the sacral region to the lumbar region. And if you think why this happens, because of many things. Because of the growth of the embryo caudal to the kidneys, so there will be like relative ascent of the kidney. Also, there will be a reduction of the size of the organs, surrounding organs like the gonads. They are first big and then shrink or get smaller. And also the mesonephros will degenerate, so there will be room for the kidney to ascend upwards. What about the anomalies of the kidneys? We have so many anomalies. We could divide them in the following: anomalies in the number, the decrease of the number or increase of the number, and the problem will be in the ureteric bud. So if there is no ureteric bud, there will be agenesis of the kidney, because the ureteric bud is the stimulant for the formation of the definitive kidney, because it stimulates the mesoderm at the sacral region to develop the metanephric cap, and together they will form the kidney. So if there is no ureteric bud at one side, this is the unilateral agenesis of the kidney. If it is lacking on both sides, we call it bilateral agenesis, and of course it is incompatible with life. And if you remember from the general anatomy lectures, you could actually diagnose agenesis of the kidney during intrauterine life by oligohydramnios, because the kidneys are one of the sources of production of amnion. So if there is agenesis of the kidneys, there will be oligohydramnios with all its complications like adhesions and pressing over different parts of the embryo and asymmetrical growth of it. Also, if we have increase in the number of the ureteric bud, like early splitting of the ureteric bud or double ureteric bud at one side, we will get, or we will end up with a supernumerary kidney as shown in this X-ray. The anomalies could be in the shape of the kidney, as in the case of polycystic kidney, and could be explained by what's called non-union theory, in which there is no union between the collecting unit and the excretory unit of the kidney. So if you look at this diagram, this is the shape of the normal kidney, and this is what's called a polycystic kidney. Poly means a lot or many, and cystic means sac containing fluid. This is a real picture of a normal kidney, and this is how the polycystic kidney looks like. Also, abnormalities in the shape could be presented by what's called lobulated kidney. The explanation of the lobulated kidney is actually unknown, and you end up with a kidney which is formed of many lobules. This is not a normal appearance of the kidney. Also, in the shape, we could end up with what's called horseshoe-shaped kidney. And the problem is that there is lack of separation of the two metanephric masses from the right and left sides. So you end up with two kidneys attached by their lower poles, and they look together like a horseshoe-shaped structure or U-shaped structure. They try to ascend, the both kidneys try to ascend till they are trapped by the inferior mesenteric artery, which arises from the ventral aspect of the ureter. And also it is associated with ureters which lie anterior to the kidney, not posterior as in the usual position. The anomalies of the kidney could affect their sides. Of course, you know that the normal side of the kidney is in the lumbar region, but sometimes we have ectopic kidney, and this is because of the abnormal migration of the ureteric bud and the metanephric cap. So we could end up with pelvic kidney, iliac kidney at the iliac crest. Crossed kidney comes from the left and migrate to the right side. We could have even thoracic kidney. Also, the anomalies could be in the blood supply of the kidney. We end up with supernumerary renal arteries, and this is because of failure of degeneration of the segmental arteries during ascent of the kidney. So during ascent of the kidney, the kidney takes its blood supply from the aorta, and when it ascends one step higher, this artery will degenerate and the one above it will persist and supply the kidney. However, like in this diagram, you could see this aorta and the renal artery enters the kidney, and below it lies an abnormal or accessory renal artery, like this one, also shown in this radiological picture. The anomalies of the ureters, either in the number, and this is because of premature division of the ureteric bud. So we could end up with double ureters, either partial double ureter, like this. They are double higher up, and then they unite again as a single ureter, and they will open in the urinary bladder as a single orifice, as in this picture. Or the duplication could be complete, like this one, and both ureters enter or end separately at the urinary bladder. Also, the abnormalities of the ureters could be at their site of termination. This happens when there is another ureteric bud arise from the mesonephric duct. So we have ectopic ureter. If you look at this diagram, the yellow ureter here is the normal one, and the one in red is the abnormal or ectopic one. and you can notice its termination is abnormal. Either it opens into the vagina, for example, or the urethra, or even at the perineum. Also, the structure of the ureter could be abnormal, like if there is abnormal canalization of the ureter, so we end up with atresia or complete failure of getting a lumen inside the ureter, we call it atresia, or stricture or narrowing of the lumen of the ureter, we call it stenosis. And sometimes there is folds inside the ureteric lumen made by the mucosa. Here you can see if there is a stricture here or stenosis here. Because of the stenosis or the strictures or the presence of the folds, urine will accumulate or stagnate at the upper segments, and there will be back pressure of the kidney, and this back pressure will lead to infection, and later on the patient might end up with renal failure. This is the end of my presentation, and I hope you like it. Thank you.